So finishing out the course for today is one of the course directors, Adam Schaffer, who you met earlier. Adam is an assistant professor of medicine, part-time at Harvard Medical School, and he is the director of our general medical consultation service at Brigham and Women's Hospital. And Adam today is going to be talking about current and emerging concepts of perioperative medicine. Welcome, Adam, again.
Hey, thank you so much. First, I want to say I am unequivocally supportive of conferring omnipotence upon Dr. Strider, so we need to work on that. So yeah, I'm really pleased to have the opportunity today to speak with you about preoperative evaluation. I have no financial disclosures. So some of the objectives we have before us today is we want to review some of the perioperative key perioperative guidelines. We're going to review some of the risk assessment tools. We're actually not a specific bullet point here, but there's actually been some interesting relevant articles that have come out in the perioperative literature, some within the last 1 to 2 months. So we're going to talk about some of what's new in the literature. And some of those articles relate to perioperative medication management. So we're going to talk about that. And we also want to think about some of the population-specific perioperative considerations. So to start with a clinical case, and this is a real clinical case, and I picked it because I consider it sort of archetypal rather than it being particularly unusual. So we can imagine a 76-year-old male with a history of COPD on 3 liters of home oxygen, also on sort of low to moderate dose chronic prednisone, diabetes, taking metformin. He has dyspnea with minimal exertion. His EKG is basically normal, no major cardiac history. He has metastatic colon cancer with a single metastasis to the brain, causing some left arm weakness. And you're seeing him in consultation prior to neurosurgery, which of course is scheduled 48 hours from now with the plan to resect the brain metastases. And as the patient emphasizes to you, he knows he's going to be fine because he tolerated the resection of the colon mass 3 years ago without any issues. So we're going to return to this case at the end, and I'm hoping, after we go through some of the material, you'll feel, hopefully maybe even more comfortable approaching a case such as this. So first, talking about what is our role as hospitalists seeing a patient as a preoperative in preoperative consultation. So I want to say, we should not be declaring that the patient is somehow cleared prior to surgery. I always sort of wince when I work with residents and they say in the chart, the patient is cleared for surgery, because we're really not in the position to warranty that it's going to be smooth sailing for any given patient. So what we should be doing instead is to assess the patient's cardiac and other risks going into the procedure. Decide, is there specific preoperative cardiac or other testing that's indicated prior to surgery? Think about medication management preoperatively. For instance, are there medications that we should be adding for the sake of reducing cardiac risk, such as beta blockers? Are there medications that we should hold to reduce perioperative risk? And this last bullet point, I think, is one that sometimes isn't given the attention that it warrants, which is reviewing again, what are the balancing of the risks and benefits. Because I found sometimes patients are sort of hurtling towards surgery, and it's just taken for granted that yes, they should undergo surgery. And having a fresh set of eyes, think about what are the risks here, what are the benefits here? Are we confident that the risks outweigh the benefits? That's a really useful role that we can play that I feel like sometimes gets de-emphasized more than it should. So the primary guidelines are frankly getting a little bit old, but the 2014 ACC AHA guidelines are still the major guidelines that we follow. This is the sort of the 10,000-foot view here. Many of you, I suspect, are quite familiar with these. I'll spend just a few slides just sort of refreshing your memory about these. So, as a first step, we consider, is it an emergency procedure? If it is, then we have to go to surgery, and we do the best we can with any risk stratification and any risk mitigation. Is it an acute coronary syndrome? If so, typically we'll put the brakes on surgery. Certainly, then we're going to involve cardiology. We want to evaluate and treat, pursuant to goal-directed medical therapy. But for the vast majority of cases that we see, they're not emergency procedures. There's no acute coronary syndrome. So in that setting, which, as I said, is just about every case, then the first step is going to be to consider what is the patient's risk of a major adverse cardiac event, which is defined as death or MI. And of course, the MACE risk is a function of both the patient-specific risks and the procedure-specific risks. And the pertinent threshold in the guidelines is 1%. So if the risk of a major adverse cardiac event is less than 1%, then that patient is considered low risk, and you're generally going to proceed to surgery. If the patient's risk is greater than 1%, then you're going to consider functional capacity, and I'll talk more about that in a moment. So as a first question, what tools should we use to assess what the MACE risk is? There are a number of different tools, and what we use now is principally some of the online risk calculators. Number one there is the American College of Surgeons, a National Surgical Quality Improvement Surgical Risk Calculator. There's also the Perioperative Cardiac Risk Calculator, sometimes called the MICA calculator. And then there's also the RCRI score. Here we see the NSQIP surgical risk calculator, and I'll say I am a strong and unabashed proponent of this NSQIP calculator. I consider this the sort of tool of choice to ascertain MACE risk. You can see you have to do a fair number of inputs, but certainly once you get comfortable with it, it doesn't take very long to use. And the reason this is my favorite calculator is because of the output. So you can see here, it gives you the risk in multiple different domains. So it gives you the risk of cardiac complications, and that's what corresponds to the MACE risk. But it also gives you the risk in multiple other areas, which is really important. For instance, what is the risk of pneumonia? What is the risk of a serious complication? What is the risk of VTE? What is the risk of death? The most robust risk and benefit discussions with the patient happen when you consider risks in all of these domains. Indeed, I think one of the most common missteps I see when it comes to cardiac evaluation is when I sort of like the cardiac blinders, that one considers what is the risk of cardiac adverse events while neglecting to give appropriate weight to the risk of non-cardiac adverse events. So this calculator is really helpful in sort of keeping your eyes focused on both cardiac and non-cardiac risks. So here we see the perioperative cardiac risk calculator, sometimes also called the MICA calculator, because predicts risk of myocardial infarction or cardiac arrest. You can see it has fewer inputs, just age, creatinine, ASA class, preoperative function, and procedure, but it also gives you less output because it basically just gives you that MACE risk. And doesn't give you the risk in those other domains, which is one of the reasons why I'm a fan of the prior NSQIP calculator. And finally, we have the Revised Cardiac Risk Index, the RCRI. This is basically a list of 6 risk factors, which you see detailed there, sort of things you'd expect: history of ischemic heart disease, history of congestive heart failure, and so forth. So I'd say there's a little bit of a soft spot for the RCRI locally because it was developed by Brigham investigators on Brigham patients. That said, it does perform less well. An RCRI score of 2 or more generally corresponds to a MACE risk of greater than 1%, but as it performs less well relative to the two online risk calculators I just reviewed, in part because it actually wasn't designed to predict MACE risk. It was designed to predict a slightly different set of adverse cardiac events. So, pursuant to the guidelines, as I said, if your MACE risk is less than 1%, then you're considered to be low risk, and generally you're going to proceed to surgery without further testing. If your MACE risk is greater than or equal to 1%, then you're generally considered at elevated risk, and that's when you need to take into account the patient's functional capacity. So most people use a functional capacity of 4 METs, although I will note that's actually the 2B threshold, and 10 METs is the 2A threshold. But if the functional capacity is greater than or equal to 4 METs, then you're generally going to proceed to surgery, even if the patient's MACE risk is greater than 1%. In terms of assessing whether the patient makes 4 METs, a lot of people I frequently see sort of the anecdote of, are you able to, or at least the question of, are you able to walk up a flight of stairs with a bag of groceries as corresponding to 4 METs? I sometimes like to use the Duke Activity Status Index, which is a standardized set of questions, which then gives you a score, which then that score can be translated into what METs value they make. It's not a 1-to-1. If you're there are various calculators you can use. You see the link there, which allows you to plug in the answers to the Duke Activity Status Index, which will then be translated into what METs value they make. And in general, a Duke Activity Status Index score of at least 34 is associated with a reduced risk of 30-day death or MI. And if your functional capacity is less than 4 METs, then you'll consider then you're going to consider pharmacologic stress testing if it will change management. And I very intentionally highlighted if it will change management, because particularly as hospitalists, we're often called in, when the procedure is urgent, and even in that setting, a stress test may not change management. To provide a example that often comes up is in the setting of a femoral neck fracture. When you have a femoral neck fracture, delaying surgery leads, we'll review these data in a little more detail later, but when you have a femoral neck fracture, delaying surgery, greater than 48 to 72 hours is associated with, adverse outcomes. And, in that setting, it's usually not feasible to revascularize the patient. And, so it's unlikely that a stress test will change management. So, if they have a MACE risk greater than 1% and a functional capacity less than 4 METs, it shouldn't be a knee-jerk reaction to get the pharmacologic stress test. You really want to sort of plot it out a few steps ahead and say, is this data actually going to change my management? And when you think about how the results of a stress test can change management, I think it is sort of two major ways. One, will the stress test determine whether I revascularize the patient if it's positive? And for that to be the case, among other things, you need to be comfortable delaying the surgery, usually by a few months, because most of the time while they're on antiplatelet therapy, you're not going to want to have them undergo surgery. But another thing which I've sort of appreciated more, only in the last few years, is another way a stress test can change management is if the surgery isn't absolutely critical. Let's say it's for severe arthritis that's affecting someone's ambulatory status in their knee, such that it's not clear that they certainly don't urgently need the surgery. If a positive stress test will mean that you defer surgery in general and you decide not to go forward with surgery, even if revascularization isn't on the table, that's another way that the stress test results will potentially change management. So this is a article that was published in JAMA Cardiology, about 3 years ago, and it makes a few important points. Probably the most important point is on the right here. So on the right there this was a large cohort of patients undergoing orthopedic surgery, about 800,000 of them, as you can see. And the table on the right says what percentage of them with an RCRI score of 0 underwent preoperative stress testing. And you can see overall, roughly half of patients who had an RCRI of 0 underwent cardiac stress testing. So that tells us we're certainly overusing preoperative cardiac stress testing, because it's hard to imagine too many scenarios where a patient with an RCRI score of 0 needs a stress test prior to surgery. But on the left there is a little bit encouraging, in that we see that stress test use over time is going down, and you can see when stress tests are used preoperatively, most of the time they use a nuclear stress test, which I think is usually the right answer for a preoperative cardiac stress test. Just in case someone wants to ask me this at the end, I can tell them up front that we don't really know. The authors did not have a great explanation for that inflection point that you see around 2006. So in this idea of overusing preoperative testing, this is something that started to enter the sort of the popular literature and the popular consciousness. This was an article in the New York Times from late 2021, where they talked about basically the excessive use of preoperative testing. So as more people become aware of this, and including in the lay literature, it's possible people are going to ask you about this and maybe even challenge you a little bit as you recommend preoperative testing. So, preoperative EKGs, what the ACC AHA guidelines tell us, which is only moderately helpful, and these are all generally class 2A or B recommendations, is that preoperative 12-lead EKG, it's reasonable in patients who have known coronary heart disease, significant arrhythmia, or any real known cardiac disease, except if they are undergoing low-risk surgery. So even if they have some heart disease, if they're undergoing, let's say, cataract surgery, they don't really require an EKG. Preoperative EKG, it may be considered in asymptomatic patients without known coronary heart disease, except those undergoing low-risk surgery. And as you see there on the bottom, a class 3 recommendation, which is something that they're recommending that we not do, is that we should not be getting routine EKGs preoperatively in patients undergoing low-risk surgical procedures. So again, all our patients undergoing, cataract surgery and low-risk procedures, where a lot of them get filtered probably unnecessarily through the preoperative evaluation process, there is not an indication for EKGs in those patients. So one area where there's actually been some fairly recent evolution is in the use of perioperative troponins. So if you look at the 2014 guidelines, they say that you can sort of consider it in patients. They basically say that the 2014 guidelines say that perioperative troponins, their value is uncertain, and they basically didn't recommend that as a practice. If you look in the 2018 European Society of Anesthesiology guidelines, they say that they would consider an assessment of cardiac troponins both pre and post-operatively, in high-risk patients. And here you see the more recent set of guidelines for the European Society of Cardiology. You can see here that they basically do recommend pre and post-operative troponins in most patients, except those who are younger, less than 65, without known cardiac disease, who are undergoing lower intermediate risk surgery. But essentially, everyone who's undergoing high risk non-cardiac surgery and those undergoing intermediate risk non-cardiac surgery who are older or who have known cardiovascular risk factors or disease, they do recommend perioperative troponins. So, some of the questions one should think about in terms of doing perioperative troponins, of course, is how is it going to change your management? And as I said, the trend has been to do them more frequently and realize that they can potentially change management in a number of ways. For instance, if they're elevated, it's going to prompt an assessment for the etiology. Could the patient have a PE? Why are the troponins elevated? It can also inform decisions to intensify the cardiac therapy. For instance, if they're not on it, it might be the basis for the decision to add an aspirin or statin. It might alter the intensity of monitoring if it's going up, even if they're on intensive medical therapy. Are you going to then you may do telemetry monitoring, maybe even consider monitoring them in the ICU. And some people have even said it counts as changing management if, let's say, even if you're not going to change monitoring or treatment in the hospital, that may mean that you decide to send them to a cardiologist for outpatient follow-up in the short term, which you wouldn't have otherwise done. And most of the guidelines that recommend checking troponins say you should do it both pre and post-operatively, because otherwise the post-operative troponin can be difficult to interpret. Although some people, a smaller group of clinicians who are critical of this recommendation, have made the point that an elevated preoperative troponin can sometimes get in the way of the patient proceeding with surgery. So thinking about the role of beta blockers perioperatively, perioperative beta blockers do appear to be of benefit in select patients who are at elevated risk of perioperative cardiac events. We spend a lot of time wringing our hands about who should be started on beta blockers and what the time frame and so forth, but you'll be in pretty good shape if you can just remember the single class 1 indication for perioperative beta blockers, which is if the patient is on beta blockers long term, then they should be continued on beta blockers perioperatively. The thing you don't want to have happen is you don't want to have the beta blocker fall off perioperatively if they've been on it long term. Pathophysiologically, that intuitively makes, at least to me, quite a bit of sense. Imagine the adrenergic surge of surgery and induction of anesthesia. That's not the setting in which you suddenly want to have that long-term beta blocker no longer be on board. The issue, which is much less well settled, is what should we do for a patient who may have an elevated cardiac risk, but who isn't on a beta blocker already. Many of you probably know the POISE trial, which is still probably one of the most prominent trials of beta blockers. It's probably, at least to my knowledge, the largest prospective RCT of beta blockers. And in the POISE trial, they randomized 8,400 patients who are undergoing non-cardiac surgery with at least one cardiac risk factor. So they're aiming for principally an intermediate cardiac risk population, and they were randomized to either placebo or controlled release metoprolol, which was given 100 milligrams 2 to 4 hours before surgery. There was then a post-operative dose after surgery based a little bit on heart rate and blood pressure. And then the patients got 200 milligrams of the controlled release metoprolol orally daily for the next 30 days. And I will say that the beta blocker could be held with certain heart rate or beta blocker, certainly with certain heart rate or blood pressure parameters. So there were hold parameters, but there was no titration of the beta blocker in this trial. So for the primary endpoint, which was 30-day cardiac events, it was lower in the beta blocker arm compared to the placebo arm. The 30-day cardiac event rate was 5.8% in the beta blocker arm, which was significantly lower than the 6.9% in the placebo arm. The reason this trial has, initially and continued to generate a certain amount of consternation in those of us who do perioperative medicine is that the mortality rate was higher in the metoprolol group at 3.1% compared to the placebo group at 2.3%. And I wouldn't be surprised if many of you have already intuited, something which bothers people about this trial, which is, I'm sorry, I should have said up front, all these patients were beta blocker naive, that if you have a group of beta blocker naive patients, putting them on 200 milligrams of metoprolol a day, that's an awful lot of beta blocker for patients who haven't previously been on beta blockers. And that's the thought about what increased the mortality rate, that the ischemic stroke rate was roughly double in the beta blocker arm compared to the placebo arm. So the thought was this was so much beta blocker that, yes, it was having an anti-ischemic effect, but it was also causing their blood pressure to drop and leading to ischemic strokes. And that effect from the strokes offset any beneficial anti-ischemic effect. So sorry, as you see there, bottom line takeaway is that giving high doses of beta blockers without dose titration to beta blocker naive patients right before surgery increases mortality. So showing at least a potential benefit to beta blockers if they're employed perhaps more carefully is this large retrospective study, almost 700,000 patients, which basically compared patients on beta blockers who were compared to patients not on beta blockers stratified by their RCRI score. And you can see here, just to orient yourselves about this study, the x-axis there is the odds ratio for death in the hospital, and the y-axis is the RCRI score. So as you're going down the y-axis, you're getting higher cardiac risk. And as you can see, as cardiac risk increases, as defined by the RCRI score, the odds ratio for death in a hospital decreases for patients on beta blockers compared to patients who aren't on beta blockers. So, in this trial, as the RCRI score goes up, the benefit from beta blockers appears to increase. And you can see there, the tipping point appears to be an RCRI score of 3. So once patients had an RCRI score of 3, there did appear to be a benefit from beta blockers. But again, this was a retrospective study. So when we look at what is the 2014 ACC/AHA guidelines tell us, is it's basically consistent with what we saw in the POISE trial and to some degree in that other trial, or that other study, I should say, that so in patients with with an RCRI score of 3 or more, it may be reasonable to begin beta blockers prior to surgery. That's a class 2B recommendation. But probably the bullet point there on the bottom is what's most critical for us as hospitalists, which is beta blocker therapy should not be started on the day of surgery. So if you're seeing them, right before surgery, within, let's say, 24 hours prior to surgery, you don't want to start them on a beta blocker for the sake of perioperative cardiac risk reduction. Though I do want to give the caveat that if let's say they're going into AFib prior to surgery and you want to give them the beta blocker for AFib or for a separate indication, that's probably going to be reasonable. But if you're thinking about starting a beta blocker, solely for perioperative cardiac risk reduction, then you don't want to start that beta blocker, on the day of surgery. So now turning our attention to perioperative statins, which I feel like sometimes get less attention as a tool to reduce perioperative risk. But the data really support their value in this role. So one of the more prominent trials here is the DECREASE-3 trial, which enrolled about 500 patients who were at elevated cardiac risk, scheduled to undergo non-cardiac surgery. All patients were statin naive, and they of course, in designing the study, wanted to didn't want it confounded by beta blocker usage, so they made sure every patient was on beta blockers. If they were already on beta blockers, they were continued on beta blockers, and if they weren't already on beta blockers, they were started on beta blockers. Though here they started it 30 days prior to surgery and titrated it. They didn't start it right before, as we saw in the POISE trial. And they were randomized, so all these patients, all of whom were statin naive and on a beta blocker, they were randomized to fluvastatin 80 milligrams daily or placebo. Probably like me, you use fluvastatin roughly never. So a quick notice of why they used fluvastatin here. So fluvastatin is a moderate potency statin. The appeal of fluvastatin for the sake of this trial is that fluvastatin has among the longest half-lives of any of the statins. And the rationale was that patients may be NPO in the day or so, either prior surgery or after surgery. So they wanted to avoid any sort of issues with statin withdrawal confounding the results. There's actually a little bit of data suggesting that statin withdrawal around the time of surgery, may have an adverse impact. So they picked fluvastatin, high dose fluvastatin, because of its long half-life. And the fluvastatin was started 30 days prior to surgery and continued. The protocol was for at least 30 days after surgery. So you can see here for the primary endpoint, perioperative myocardial ischemia, the statin arm had 10.8% compared to 19% in the placebo arm, which is good to see, but ultimately that's a little bit of a squishy endpoint. When you talk about just myocardial ischemia, that included things like ST deviations and so forth. The reason I think this trial made it into the New England Journal is because of this secondary endpoint on the right, which is the more compelling and harder endpoint of perioperative death from a cardiovascular cause, or MI. So for this, more compelling outcome, the statin arm, it roughly halved it compared to the placebo arm, 4.8% compared to 10.1% in the placebo arm. And for those of you who still may be skeptical, this was a meta-analysis looking at the effect of statins perioperatively in terms of the odds ratio, the odds ratio of death, and you can see the results was a quite impressive. You can see they're an odds ratio of 0.54 with the upper 95% CI being 0.78. So a impressive magnitude of the reduction in the odds ratio for death for patients on a statin in this meta-analysis, as you can see there. And I personally am, so I'll certainly start statins in patients. Let me get that exact. So statins, what do the guidelines tell us? The statins should be continued in patients who are currently taking statins, who are scheduled for non-cardiac surgery. That's a class 1 indication. Perioperative initiation of statins is reasonable in patients undergoing vascular surgery. That's a 2A recommendation. And then perioperative initiation of statins can be considered as a 2B recommendation in patients who basically have a clinical indication for statins more generally, who are undergoing elevated risk procedures. I'll often start patients on statins if they otherwise have an indication for them in the perioperative setting. And the reason is we saw how in the POISE trial, employing beta blockers sort of ham-handedly, can do harm to patients. As we saw with the increased risk of ischemic stroke, there's no real sort of corresponding risk with statins. If one looks at the rate of adverse events for the use of statins perioperatively, things such as myalgias and rhabdomyolysis, the rates of the typical in elevated LFTs, the rates of the common adverse effects of side effects of statins, they're pretty similar in the perioperative setting as they are outside of the perioperative setting. So for that reason, I consider the risk-benefit calculus often is favorable for starting statins perioperatively. So what should we do with the aspirin perioperatively? It was only, for many years, we didn't actually have good prospective RCT data to answer this question. With the POISE 2 trial, we received these data. So this was a very well-designed prospective RCT that enrolled 10,000 patients undergoing non-cardiac surgery who were at risk for vascular complications. Patients in the coronary stent critical periods were excluded from the trial. And the primary endpoint that they looked at was death or non-fatal MI at 30 days. And then patients were stratified for whether it was basically a 2-by-2 stratification. So patients who were already on aspirin, half of them were continued on aspirin, half of them had their aspirin stopped. For the other half of patients who were not already on aspirin, half of them and half of them were started on aspirin. And the results were basically unequivocally negative in terms of the benefit of aspirin. There was no benefit to aspirin in the primary outcome or any of the secondary endpoints that they looked at. There's also no benefit to aspirin in any of the subgroups that they looked at. And as you might expect, taking aspirin was associated with an increased risk of major bleeding. So here you see a little bit of a more detailed look at the results. So that the lines were superimposed overall may not be very surprising. However, I was a little surprised that even in the subgroup analysis there was no benefit For instance, it's not hard to imagine that maybe aspirin would be benefit specifically in patients who are undergoing vascular surgery, or specifically in patients with a high RCRI score, but they were not able to show a benefit to aspirin in any of the subgroups. This of course doesn't mean that I necessarily stop aspirin in all of my patients who are undergoing surgery, but it means when I am discussing the risks and benefits with the surgeon in terms of the bleeding risk and so forth, I certainly take this into account. And if the patient is a patient of the sort, the moderate risk patient outside the stent critical periods that were included in this trial, if the surgeon has major concerns about the bleeding from aspirin, I'm certainly more willing to hold it in light of these data. So aspirin was not beneficial in reducing 30-day death or non-fatal MI overall or in any of the subgroups. So one thing which I often get asked about and was often debated is what should we do with the ACE and the ARB? I'm actually very pleased to be able to say this was I slipped in a trial. This was published actually within basically the last 6 weeks, and it was finally a large prospective RCT of holding whether or not the ACE or the ARB should be held perioperatively. So we've been sort of waiting for a trial like this to come out, and I'm very pleased that this came out. You can see it was published online on August 30th and was formally published in JAMA on September 24th. So it was a prospective RCT of about 2,200 patients in France. They had to have been on a ACE or an ARB for at least 3 months. And then they were randomized 1-to-1 to either continue the ACE or the ARB up until the date of surgery, or to hold the ACE and the ARB for at least 48 hours prior to surgery. And when you look at the results here, there was basically no difference in the primary outcome of all-cause mortality or major postoperative complication. I believe that was at 30 days. So yeah, there was no change in the primary outcome in the patients who were continued on the ACE and the ARB compared to the patients who weren't. A big question that often comes up is, so what about hypertension versus heart failure? If for this data really to be actionable, we want to have some sense of the subpopulations, and they did break it out by subpopulations. This isn't all of them, but for me, the real question was heart failure patients, and you can see there was no benefit, no significant benefit to discontinuing versus continuing the ACE or the ARB based on whether the patient had heart failure or not. So no difference between the groups, both for the patients with heart failure and the patients without heart failure. It is worth noting that you can see the confidence interval for the heart failure equals yes. It's fairly wide because only about 6% of the patients had heart failure. So still may have been underpowered to detect a difference with heart failure patients. But this is still basically the best data we have overall and the best data available for heart failure patients in terms of whether we should hold the ACE and the ARB. And what this trial tells us is there's not a clear benefit to holding the ACE and the ARB. I'm actually going to make the potentially somewhat provocative suggestion that I'm not actually really sure that this study, as important and useful as it is really going to change management, because what's a fairly conventional practice, and this is what the guidelines most of the guidelines weekly suggest, which is if they're on the ACE and the ARB just for hypertension, then frequently we'll hold it in that setting, and if they're on it for heart failure, we're more likely to continue it. And even after these data, I think that's probably still going to generally be my practice. So another thing I want to talk about, not because we have great data, but just because it's generated a huge amount of discussion, is what to do with the GLP-1 agonists. Should we hold those for around the time of surgery? What should the timing of be? So what do we do, especially now that the size of the population on the GLP-1 agonists is really exploding. I'm not going to be able to show you great data to tell you what to do. I can give you sort of the applicable guidance from the sort of authoritative professional organizations. So what the American Society of Anesthesiologists say is for patients who take GLP-1 agonists daily, you want to consider holding the medication on the day of surgery. For patients who take GLP agonists weekly, you want to hold it for 1 week prior to surgery. If the patient has GI symptoms such as bloating or nausea, vomiting, consider delaying the procedure. If the patient has no GI symptoms but didn't hold their GLP agonist, then you may want to use what's known as full stomach precautions, in assuming that you're intubating them in the setting of their stomach not being empty. So this is what the American Society of Anesthesiologists say. These sort of recommendations have been subject to a fair amount of criticism, and I'm right there is sort of the key issues that people have been sort of concerned about when I think about these recommendations. So for one thing, if one looks at the data about, there's a handful of studies that have looked at the results of patients who are undergoing upper endoscopy and stratified them by whether the patients were on GLP-1 agonists, and then tried to answer, does it look like there's retained gastric contents in patients who are undergoing GLP-1 agonists noted on upper endoscopy? And the short answer is not clearly yes. Some of the studies have found yes. Some of the studies have found no, but certainly the answer has not consistently been yes. As some people have also noted, the duration that we should be holding the GLP-1 agonists in order to reduce the risk of retained gastric contents isn't clear, particularly the idea of holding them 1 day prior to surgery. It's not clear how much that's going to reduce the risk of retained gastric contents. And especially given that it's unclear how much holding the GLP-1 agonist really reduces the risk of retained gastric contents, there's the concern that, the potential for worsened glycemic control, maybe that is offsetting in terms of us thinking about it. So, I can't give you a sort of clear bottom line answer, but hopefully that sort of gives you some of the appropriate context as we talk about it with the anesthesiologists. So I think we've seen some other talks that have touched upon the perioperative management of diabetes. So I'm not going to sort of go through this line by line, but I put this in because I consider it sort of a helpful guideline. So sort of for reference in terms of what you want to do with the patient based on whether or not they're on insulin and whether they're type 1 or type 2. I will say generally we hold most of the oral agents prior to surgery, and you can see some of the more granular advice there. So you'll have this as reference. So bridging anticoagulation, this is a trial that I used to give a lot more attention to, and I've now, I think, cut it down to only 2 slides because it looked at the issue of what do we do perioperatively with patients who are on AFib and who are on Coumadin or patients with AFib who are on Coumadin for their AFib. Of course, the proportion of patients whose AFib is treated with Coumadin is, of course, going down as we have probably most of our patients on DOAC as their anticoagulation. So the importance of this trial has receded. That said, it was pretty well designed, and it looked at patients with AFib on Coumadin who were scheduled for elective surgery and randomized them to either low molecular weight heparin as dalteparin or placebo. These patients were generally at intermediate risk for thromboembolic events from their AFib with a CHADS-2 score of 2.3. And we see the results here, which is for the primary endpoint of any arterial thromboembolism, no significant difference between the groups. So at least in these intermediate risk patients, it's not clear that if you hold the Coumadin, it doesn't support the need for bridging anticoagulation. Yes, I want to emphasize that these were patients who are at intermediate risk of thromboembolic events. So if you have a very high CHADS-2 score, very high CHADS-2 VASC score, then bridging anticoagulation probably is still appropriate. As I said, most of our patients who are on DOACs. So here you see some sort of helpful guidance about how you handle the DOACs perioperatively. Again, I'm not going to go through all of this line by line, but I think the main thing to flag is the particular risk is with dabigatran in patients who may have renal insufficiency. So you can see if a patient's undergoing a procedure with particularly high bleeding risk and they're on dabigatran and their creatinine clearance is less than 50, then you want to hold that 4 days prior to surgery. But I said this is a very helpful graphic that was published in September of this year. So within the last month, which provides very practical guidance on the appropriate holding of the DOAC perioperatively. So now for our last few minutes, and wow, time flies. It is our last few minutes. I want to talk about perioperative pulmonary complications. So perioperative pulmonary complications are considered by many people, including me, to be less interesting, just because yes, they're important, yes, they're common, but we have sort of fewer levers to pull to try to prevent them. So, what do we when we talk about perioperative pulmonary complications? We're talking about things like, respiratory infections, atelectasis, pleural effusions, aspiration, and so forth. On the left there, you see it's a risk score for that helps you stratify patients in terms of what their risk is of perioperative pulmonary complications. Most of the risk factors there are going to be unsurprising. Age, what is their preoperative pulse ox level, and so forth. The one I want to highlight, because it may be a little bit less obvious, and because if you look at the score associated with it, it's particularly impactful, is the site of the surgical incision. So the closer the site of the surgical incision is to the diaphragm, the higher the risk of pulmonary complications. And a mechanism for that seems very, very plausible, which is if the surgical incision is very close to the diaphragm, then it's going to be particularly painful to take a deep breath, and you're going to be splinting, taking a lot of shallow breaths, and that's a setup for atelectasis and other pulmonary complications. So that's probably what mediates it. There is data at patients who are at elevated risk of pulmonary complication. Lung expansion maneuvers do appear to be helpful. That includes things such as intensive spirometry, lung expansion exercises, and also CPAP. There's no particular data that says one of those is better than the other. One thing I will often do with patients is do what I call an artificial yawn. If I'm concerned about the risk of atelectasis, yawning probably evolved as an anti-atelectatic adaptation, so that when we get tired and our minute ventilation goes down, yawning helps expand our lungs. So that's something a number of people have recommended, and certainly very low risk and very low cost. Indeed, I appreciate the fact that in support of this talk, I bet many of you are yawning right now. So thank you for that. Some of the other perioperative pulmonary risk reduction strategies. One I want to mention is smoking cessation. So there's actually 2 studies that have shown that smoking cessation right before surgery, in the 1 to 2 months prior to surgery, may actually be associated with an increased risk of pulmonary complications. Why that is, we basically don't know. There are a few hand-wavy explanations that it's not really worth my time trying to explain. But I actually want to make very clear, I am talking about this just for the sake of standardized tests. If you're taking a standardized test and your patient is undergoing surgery in, let's say, 2 weeks, the right answer for perioperative risk reduction is not stop smoking. In real life, of course, anytime my patient is on board with stopping smoking, I'm going to support that. But when you see it on the ABIM, LKA questions, that's probably not the right answer. The other thing is anesthesia techniques. For a long time, we assumed that neuraxial anesthesia had lower risk than general anesthesia, and more recently, we've actually gotten some study data that shows that. So here we can see that the risk of any one complication and the risk of intraoperative complications is lower with regional anesthesia compared to general anesthesia. So that's one thing that often I think that gets neglected in the discussion with anesthesiologists. Sometimes they'll be very concerned about putting a patient, how they'll do with general anesthesia, and maybe, let's say, because they have COPD. If you're really concerned about how a patient is going to do with general anesthesia, one thing to ask the anesthesiologist is, does the patient really need general anesthesia? Because I've always been impressed with how sort of creative and innovative our anesthesiology colleagues are, that if we're really concerned about the risk of general anesthesia in a patient, they can do a very large number of procedures under regional anesthesia. I've even seen a few hips replaced under regional anesthesia. So have that conversation with anesthesia. Sorry, and this is just another study that shows the same thing, that regional anesthesia does have lower complication rates compared to general anesthesia, and this was a cohort, pretty sizable cohort of propensity matched COPD patients. I mentioned earlier that the timing of surgery in hip fracture patients is important. This is a retrospective cohort analysis of about 4,200 patients with hip fractures from Ontario. The mean age of around 80 and predominantly female. I will say they did do careful propensity matching in this cohort. And you can see there the risk of 30-day mortality by basically the delay in terms of how long from arriving at the hospital before they underwent surgery for their hip fracture. And you can see there seems to be a bit of a tipping point around, maybe 36 to 48 hours, or at least maybe a little bit of an inflection point, where you see an increase in the 30-day mortality. This I consider is data that's actually I consider very, very actionable. So when you're the preoperative consultant and you have a hip fracture patient, you need a very good reason to do any significant preoperative testing, particularly cardiac echoes. There's a lot of, well, they're old and, I feel much better knowing that they don't have severe AS and that their EF is okay. Especially in these hip fracture patients, especially if it's on the weekend and that cardiac echo is really going to delay surgery, think carefully about whether it's worth the delay, in getting cardiac testing where the indication may be a little bit tenuous. So I want to speak for a moment about perioperative issues related to OSA patients. So OSA patients are at increased risk of both respiratory and cardiovascular perioperative complications. And the big point I want to make here, and this is also from my perspective as someone who spends a fair amount of time looking at adverse events in the hospital, is that if a patient is on CPAP for OSA, make sure they're ordered for their CPAP in the hospital. Having a patient post-op who takes CPAP as an outpatient for their OSA not be on CPAP is really an unforced error. That's very hard to justify, because you can imagine a patient has OSA to begin with, and then they're getting opioids in the hospital for postoperative pain relief. That's just going to exacerbate their OSA. So their CPAP really needs to be continued. Let me skip a slide. Okay, and then one thing which has gotten a lot of attention, within the last few years within the perioperative literature, is frailty. So you see there a Fried frailty index, but most of the studies that have looked at the effect of frailty have shown a effect on postoperative outcomes that's independent of a lot of the other risk factors that we imagine may sort of co-localize with old age. So you can see here, this is shown how adding frailty to, in this case, the American Society of Anesthesiology class, ASA class, 1, 2, 3, 4, and also the alone, that's the RCRI score, that when you add measures of frailty to either the RCRI or the American Society of Anesthesiology class, you get better prediction of whether or not they're likely to go to an assisted or skilled nursing facility. This is also a very interesting study that was published within the last year, which looked at the effect of doing basically enhanced preoperative evaluation in frail patients. So this was done, I believe, at the University of Pittsburgh, and they basically built into their their EHR a alert that if it automatically calculated their frailty index, and if their frailty index was elevated and they were scheduled for surgery, then it basically gave them an alert that said you have to decide to do something. There was a geriatric pre-op clinic. It could be sending the patient to the geriatric pre-op clinic, sending it to their PCP, or reconsidering surgery were some of the options, but it forced them to actively think about the fact that this patient was frail and think about what they should do about it. And the results were really very impressive. That you look after this enhanced preoperative evaluation for patients with a high degree of frailty was implemented, there was a significant reduction in 30-day mortality. There was a significant reduction in 180-day mortality. And though I didn't show the data, there was also a significant reduction in 360-day mortality, 1-year mortality. So it showed a very impressive reduction. I read the article a bunch of times. They don't really lay out exactly what the secret sauce was that was done at the preoperative clinic, but making sure you think carefully and do enhanced preoperative evaluation of these frail patients, at least in this study, was found to reduce mortality. So I thought I'd helpfully end the course on a nihilist note. So this is a study that looked at the results of preoperative evaluation generally. So it was a large cohort of patients, I believe in Canada, I believe in Ontario, where they did very careful propensity matching, and then they looked at 30-day mortality among patients who received perioperative medical consultation compared to those who didn't, in various matched subgroups. And for those who received perioperative consultation, not only was there no benefit, there was a significant increase in mortality. Why that is not entirely clear. One reason I put this study in is there's been a couple of other studies over about the last 15 years that have looked at the same thing, and they've all shown no benefit or harm from preoperative evaluation. So it's certainly worth thinking, why that may be. Some of I think there's sort of two actionable takeaways and one methodologic takeaway. So one of the actionable takeaways is we need to make sure we're targeting our preoperative resources on the appropriate patients. Because if we're doing preoperative evaluation on low-risk patients, then we wouldn't expect it to have an effect. Indeed, getting to the second way these data are either at least actionable or at least very thought-provoking is, if we're sending a lot of low-risk patients for preoperative evaluation, they're at risk of getting potentially unnecessary preoperative testing. And we saw earlier from the data that there's plenty of unnecessary preoperative testing. And then when you do that excessive preoperative testing, there may be harm from the preoperative testing. There may be harm if revascularization results from that preoperative testing, and especially there may be harm if delays in surgery result from that testing. So those are at least some of the ways where we can imagine if we're not careful about both targeting and our recommendations from the preoperative testing, that might potentially result in harm. Of course, it also may just be that, the propensity matching only gets you so far. And it may be that at least some sicker patients were more likely to get preoperative evaluation, and the propensity matching that was performed did not fully account for that, but it was done pretty carefully. So with that, I want to get back to the clinical case. Remember, this was this 36-year-old gentleman with COPD, quite severe COPD, with the metastatic colon cancer. So here's this is an older version, but when I put him into an NSQIP calculator, sort of here's what I got. So his MACE risk 1.8%, above average, greater than 1%, so at elevated risk. But at least when I looked at this, remember, because I want to emphasize, consider the non-cardiac domains. The number here that really sort of jumped out at me and was pretty disconcerting was the risk of death, which it put 1 in 4. It gave a 25% risk of death in this patient. So I'm like, okay, that certainly gives me pause. So I call up the neurosurgeon, to discuss this, kind of pretty nervous because I expected to be yelled at by the neurosurgeon, got him on the phone, sort of talked about the results, including the risk of death. And his response sort of surprised me, which was, there's been a little sort of voice inside my head telling me that this was a bad idea, but I didn't quite have the nerve to cancel surgery. Now that you're giving me these data and telling me that you also have concerns about surgery, he actually canceled the surgery while I was on the phone. There was a non-surgical alternative here, which was XRT to the brain. So that's what the patient got, and surgery remained, on the table as an option, but we certainly decided to hold off on surgery. So I think the takeaways are, here is think about the non-cardiac risk, and communicate with the surgeons, because I'm sometimes a little leery of calling them up and speaking with them, but the vast majority of the time, when I call up the surgeons to have that communication and discuss any concerns I might have, they're actually very appreciative and very respectful of the advice in the vast majority of time, in my experience. So I will leave you perhaps on that slightly less nihilist note, and if we have time, I'd be happy to take a few questions. And I just want to say thank you. Actually, I want everybody to say thank you so much for taking the course. I know it's been a long 4 days, and hopefully an information-rich 4 days. And we really, really appreciate you joining us.
Yeah, thank you so much, Adam, for that comprehensive overview on the literature and expert guidelines. We do have maybe time for like 1 or 2 questions. The most uprated question was, do you recommend delaying, I'm assuming this is emergent surgery, to correct severe metabolic or electrolyte derangements?
Yeah, I mean, that's going to unfortunately end up being sort of it depends on sort of how urgent the indication is for surgery. But I think overall, I think sometimes we're guilty of delaying surgery unnecessarily. So, if the surgery is urgent and you're delaying it, and I think the more common example I give, which I presented data about, is the hip fractures. If you're delaying surgery, make sure that you have a really good reason, and that whatever intervention you're doing, you really think it's going to lead, to, better outcomes. So most of the time, I'm sure hyponatremia is associated with worse outcomes, but most of the time, I don't think it's warranted to, let's say, delay surgery because, their serum sodium is 129 and you want it above 130. So, we need to be really thoughtful if we're delaying surgery, as a function of how urgent the indication for surgery is.
Perfect. And then just final question. If when you're using the NSQIP risk calculator and it asks for the CPT code, which if you don't know the surgical procedure the patient may undergo, what do you do in that situation?
Sure. And I was speaking up the NSQIP calculator, but yes, that's someone who's clearly used it, and that is sort of its Achilles heel, that entering the procedure can be annoying and a little bit clunky. So actually I would give a twofold answer to that. So one, I often find it works better if you put in the CPT code rather than try to type in the procedure and have it match the procedure by the name of the procedure. So what I'll often do is Google the procedure, and then Dr. Google does a better job of giving me the corresponding CPT code, which I can then put into the NSQIP calculator. And the other thing I would say is I would encourage you, even if you're getting a procedure that's close, because it's very specific of what the procedure is. And sometimes I acknowledge I'm doing a close enough procedure and I'm not confident it's the exact same procedure, but I still think that's valuable and more valuable than throwing up your hands and not doing it all. So, use Dr. Google to get you the CPT code. And even if the procedure is an approximation of the procedure they're going to undergo, I still think that's useful data to use and to act on the results from the NSQIP calculator nonetheless.
Okay, the people want one more. I know you said that pulmonary optimization wasn't particularly interesting, but still, any medications or flutter valve intensive spirometry can't hurt, but any data.
Yeah, I mean, there's not. I mean, so I think there was a Cochrane review that looked at lung expansion maneuvers and found that incentive spirometry is helpful. It also looked at the literature for like CPAP and other lung expansion maneuvers, and it showed that all of them seemed to be beneficial. The data didn't support being one over the other. So what I would say is I would encourage you to do lung expansion maneuvers in patients who are at elevated risk of pulmonary complications, but there's no data to support one over the other. So use what's available. As we all know, one of the inexplicable things about life at the Brigham is there are so few incentive spirometers. So we sort of do what we can with what we have, and we'll consider other incentive other lung expansion maneuvers. The other thing I would say about it, which I didn't put in as a slide, which is there's generally very little role for PFTs, because sometimes there's no magical threshold of PFTs below this threshold or worse than a given threshold means you shouldn't undergo surgery. Generally, what you're looking for is if they have pulmonary disease, you want that pulmonary disease to be compensated. So we have to go to surgery with some patients who have COPD. There's very few circumstances under which the COPD is going to be an absolute contraindication. But in terms of medication management, you want to make sure that their COPD is compensated. So, for instance, if it's a non-urgent procedure and they're having a COPD exacerbation, give them the burst of prednisone. Treat the COPD exacerbation consistent with what Dr. Hirsch told us, and then delay the surgery until their COPD is compensated. But if they have baseline COPD that is compensated, you're generally not going to want to delay surgery for that. But again, think maybe I want to try to do that under spinal anesthesia and not general.
Great. Thank you so much, Adam. That was a wonderful lecture.